I am Sheila Haas. I'm Dean and Professor Emeritus of Loyola University Chicago and also Nursing Research Consultant at Northwestern Memorial Hospital. This morning I'm going to give you a brief overview of my presentation on care coordination, managing the needs of complex chronically ill patients. Cancer, as you know, is a complex chronic illness. The IOM recognized this and important drivers behind the crisis in cancer care, that it's related to the population aging and to complex needs of cancer patients that go beyond cancer alone. There is a real need to move beyond single disease model of studying cancer and to embrace the complexities of managing people with complex medical conditions. Cancer as a complex disease, over the past two decades, the number of people living with cancer has increased. Worldwide, there are 33 million estimated to be cancer survivors. Many survivors end up with long-term disabilities requiring ongoing care and support. For many, cancer survival now means living with chronic and complex conditions. So consequently, cancer survivors need prevention, surveillance, intervention for consequences of cancer and its treatment, and coordination between specialists and generalist providers. Cancer survivors experience significant physical and psychological morbidity, making it necessary to minimize the burden of this disability. What survivors really require is ongoing care that's well coordinated, focuses on prevention, provides ongoing surveillance, and minimizes managing the long-term effects of treatment and other comorbidities. How can the best care for cancer patients be provided in terms of dealing with both current and potential comorbidities? I'm suggesting that nurses are the key. First of all, advanced practice nurses working in primary care, having not only the APN pediatric or adult certification, but also ONS certification. Consequently, they can provide evidence-based primary care assessment and interventions, provide preventative assessment, teaching and follow-up, and transition management. These APNs would be working as part of an interprofessional team, usually in a clinic that is an oncology clinic. Also, registered nurses with care coordination and transition management competencies can be working in ambulatory care and acute care to help maintain patient and family engagement, to provide surveillance on comorbidities, and to provide standardization of transition management communication across providers and settings. So, the care guidelines for cancer survivors have just been analyzed, and what was found is they are now a bit of a conundrum. 41 cancer guidelines were analyzed, and they were for most major cancers, and they found in this analysis that few surveillance tests were universally recommended, and when the tests were endorsed, they rarely specified how long patients should be cared and tested. And the guidelines for PET scans are also ambiguous. So this makes the job for physicians, mid-level providers, and nurses even more challenging. So what is care coordination? It's the deliberative organization of patient care activities between two or more participants, including the patient, involved in a patient's care to facilitate appropriate delivery of care services. This long definition is that of McDonald that was done for the Agency for Healthcare Research and Quality. And transition management is a broader definition than Mary Naylor's definition of transitional care. And it has to do with the ongoing support of patients and families over time as they navigate care and relationships from more than one provider and in more than one healthcare setting. And so consequently, there is a need for this management. This is the area in transitioning patients from one setting to the other and one provider to the other that errors are often made if communication is not standardized and appropriate to each patient. So the nurse management, case management, and nurse navigator roles are the ones that are most commonly known. Case management has been a long-standing way that nurses have managed care of patients, but the difference between case management and care coordination are that case management focuses on a specific case and doesn't necessarily use the standardized guidelines, evidence-based guidelines for patient populations. Oncology Nurse Navigator is another role that has been around for a long period of time. It is also subsumed under the role of care coordination and transition management, because added to this is the work with evidence-based practice and the issues of population health management and communication and collaboration in the healthcare team. So what happened was we decided to come up with a way to find in the evidence across the country the available information on care coordination and transition management, and develop the activities and ultimately develop a core curriculum so that nurses could learn to be care coordinators and do transition management. This was especially engendered by the Centers for Medicare and Medicaid, which are now going to pay for institutions that have nurses that are prepared to do care coordination and transition management. This model was guided, this project was guided by the Wagner model, the chronic care model that you can see in this slide, and it speaks to community health systems and the work of teams working with patients, activated and informed patients to improve outcomes. The other advantage of this particular project that developed the dimensions of care coordination and transition management is it used the CUSIN, Quality and Safety in Nursing Education framework, to lay out for nurses the knowledge, skills, and attitudes needed for each of the dimensions and all of the activities in the dimension. And this slide shows you the KSAs for one dimension, and all of the evidence that was pulled to come up with this particular outline. So what does a nurse doing registered nurse care coordination and transition management do? They work with teamwork and collaboration, number one of the 9 dimensions of care coordination and transition management, and this often involves huddles and interprofessional report or care planning. They establish an ongoing relationship and do education and engagement of patients and families. They do population health management, where they use evidence-based population guidelines. They do patient-centered care planning. This means evidence-based guideline interventions modified as needed based on patients' values, preferences, and goals. Assessment that is done may involve home visits, at least initially, and surveillance with the use of smartphones, Skype, patient portals, community resources, and also the use of the BOOST 8Ps protocol. This is readily available online. It was developed by the Society of Hospital Physicians, and it is a great way to assess what kinds of care the patient needs and what they are at risk for. They also do coaching and counseling, support for self-management, cross-setting communication and transition, and the BOOST protocol that I just spoke about offers standardized communication tools that patients can their patient information can be transported between organizations and between providers. Nurses also do advocacy and nursing process, which is part of the nurse's role. And what happens with all of this is we can track the impact of nurses both in their assessments, their interventions, and their outcomes when their documentation is in the electronic health record and it is coded in standardized SNOMED coding. So if you're interested in this evidence-based practice, care coordination, and transition management, there are several articles in Nursing Economics that explain the development of it and the uses of it in terms of staffing for care coordination and evaluation of nursing outcomes with care coordination and transition management. I thank you for your attention and hope that some of you really do identify with care coordination and transition management. Thank you.